My name's Kim McKenna. I am a nurse and a paramedic. I have a PhD in educational leadership and policy studies. I was teaching in EMS accidentally since the late 80s and was the program director for a paramedic program for the last 16 years of my career. And I've been working with Mick Sanders on the paramedic textbook for 25 years. I want educators to remember that the EMS Agenda 2050 says that we need to be socially equitable. And we know that in healthcare, it always hasn't been socially equitable. And I think sometimes people in EMS said, well, that's not us, that's other places that are not socially equitable. But we now know, and there's an emerging body of research that shows that sometimes patients who are not white, who don't have a high socioeconomic status, are not getting the same care as other patients. There have been some studies that show that medical students have a belief, a significant number of them have a belief that Black patients experience pain differently than white patients. They feel like there are biological differences between those two groups of patients. And the group that believed that there are biological differences in Black patients were more likely to rate Black patients' pain lower than white patients. Now, we don't have any studies on that in EMS, but that might be one of the factors that kind of explains why there are some disparities in the management of pain for Black patients. This was studied early by Bill Lord and Sahej Khalsa. They did research on some FISDAP data of the student pain management, and they found that Black patients were 60% less likely than white patients to receive pain medicine. Crow and a group recently published in the Annals of Emergency Medicine a study that they did, and they looked at 35,000 cases that were present in the ESO database. And they looked at Black patients who had a pain rating of greater than 6, which they considered to be severe pain. So that would be a pain rating of 7, 8, 9, and 10. And these patients also had confirmed long bone fractures. So there was objective evidence at the end of it all that there was a bone fracture, which I think all of us would agree is a painful thing. And what they found was that the Black patients were less likely than the white patients in that group that they studied to receive pain medicine. In fact, the Black patients only received analgesia about 59% of the time versus 72% for white patients. There were more Black patients that refused pain medicine than white patients. But this group did a really deep dive into the patients that had severe pain. And they compared Black patients and white patients to see if there was any difference when they actually read the narratives of a large number of these patient care reports. And they found that the differences that they found in people that were maybe had a contraindication or patients that really didn't want to take pain medicine because maybe they were worried about, taking an opioid, that really didn't explain that difference. They looked at socioeconomic status, and for every breakdown of the socioeconomic statuses that they looked at, that inequity still persisted, whether it was low or a high socioeconomic status. So this study really proves that there are inequities in the management of pain in Black patients. If we don't give them pain medicine in the pre-hospital setting, the mean time until they're going to get analgesia in the ER is about 60 minutes. I think that there's a tendency, particularly for those of us that work in suburban and urban EMS agencies, to think, well, I don't really have enough time, and they'll give the patient, we only have like a 10-minute ETA. They'll give the patient something when they arrive at the hospital. But that's really not good patient care. One surprising finding, though, that they found that doesn't necessarily agree with some other research studies was that folks that identified as Hispanic or were identified as Hispanic, there were no inequities there. So I thought that that was sort of kind of an interesting thing. And when you think about race as it's reported in the pre-hospital setting, it's really a social construct. Typically, you don't ask the patient what their race is. You guess at their race, and that's what you document. And so that bias may be based upon the race that you have assessed or that you have guessed that the patient is. So I think it's a really great study, and it brings up a lot of issues that really can help you teach the learners how important it is. You know, we all have bias. It's as natural as breathing. You know, you grow up with biases. Some of them are very protective. It's very important for you to recognize those bias or those potential bias and not let them interfere with patient care. You have to teach learners how to recognize potential bias in themselves, how to recognize that it might be happening when they're not leading the call, but somebody else is. And probably the most difficult thing is how to be an upstander, which is something that I'm just really learning about. You know, how to speak up, how to have those difficult conversations when you see that that might be interfering with someone's care of the patient. I think it's really important that as educators, we think about the situations that are sort of ripe for bias and ripe for improper treatment of patients that are related to bias, and set up scenarios and simulations that include those type of cases. So one of the things that you have to think about in your classroom is, what is the hidden curriculum? You know, who are your patients? And, you know, kind of how are you portraying patients? So try to think about including patients. You know, hopefully you have mannequins that have different skin color. Hopefully you have even some live simulated patients that you can use that are not all white, that are not all 22 years old, that maybe speak another language, so that you can address some of these inequities, because it's not just related to skin color. There are inequities related to gender. There are inequities related to the person's ability to speak English. There was a great presentation by Andres Camacho at the National EMS Physicians meeting this month about how if we don't identify that a person cannot understand our care and that we can't understand them, that if we don't get a translator for them very quickly, an appropriate translator for them, that's going to cause poor care for those patients as well.